Hello, everybody. So nice that you are joining again. I'm Gea Dunnik, chair from the World Psychologist, and together with Esther Hayema from PsyGlobal, we host the webinar for this evening, and she will introduce our guest for tonight. Some practical things. The webinar will be recorded and you can see it another time on both the PsyGlobal and World Psychologist website. Further, your questions, you can put them on the Q&A and we are doing our utmost best to answer them. So I wish you a very nice webinar. And Esther, will you tell more about the presenters for tonight?
Yes, tonight we have 3 experts with us, not only Luz, but also Arkady Radelov. He's originally from Ukraine and since 4 years a psychologist with the Jelinek, where you all work. And Jelinek is the Institute for Addiction and Treatment. And besides, he runs several support groups for Ukrainian refugees in Amsterdam right now. We have Sera Lortia. She's a psychologist and PhD student researching the relation between trauma and addiction. And then we have Luz Marchini. She's a clinical psychologist and she's very experienced in working with trauma and addiction. We're very happy to have you all with us tonight. And I'm very curious after your presentation. Arkady, I believe you will start.
Yeah. Welcome to our webinar, and the topic of our talk tonight will be use of psychoactive substances. So let me first tell you what we have planned for you tonight. First of all, I will start with the presenting a case from last couple of weeks. Then my colleagues will talk further. My colleague Luz will talk to you about substances and problematic use of it, and how you can talk about it with your client. Sarah will then bring to your attention a trauma in relationship to addictions. So after that, Luz will round it up with practical tips, how to start and keep the conversation about the problematic use with your client using the cognitive behavioral therapy and motivational interviewing techniques. So between the blocks, we thought to answer your questions. So let's split the questions. You can ask questions in English in Q&As, and you can ask questions in Ukrainian or Russian via the chat. So I will be monitoring the chat. Yeah, and then we do our best to answer those questions. So I want to start talking about a few words about the case of Maria. Maria is a female around 40 years old from Kiev. She is since 4 months in the Netherlands. She stays in a shelter, in a shelter for Ukrainians. She is well educated. I was asked to talk to her because people who work in the shelter noticed that she smells of alcohol, and she does not really have much in common or contact with other people from the shelter. She would stay a lot in her room. In the night, they will hear some screams. She wouldn't be coming to have food with the rest of the people. So they were really worrying about her situation. So I tried to get in contact with her. First, she wasn't really open for a talk. So I had to try a couple of times. Finally, I was in this shelter in her room, talking to her about her situation. I noticed quite a few empty bottles from wine and beer around. Now, when we start, it took time to bring the topic on addiction on alcohol, actually. And after that, when she was open to talk about that, she told me, first of all, she She was already treated a couple of times and it didn't help her. So she was in treatment and then she would start using again. After more questions, it appeared that she was a few times in the short detox programs. That was the only treatment available to her. So she had a detox, and after that she started again using alcohol. So she had an idea that the treatment doesn't help. We will use this case to come back to it and to see what could be done, what we could do to help her with her complaints. Now, that was the case. I want to introduce my colleague Luz, and she'll take it further. Luz.
Thank you, Arkady. Before we're going to talk about substances and talking about substances, I want to do the poll, Esther. Can you introduce the poll? We have 6 questions, and we will ask you to answer them all, and then we have an idea of what we are going to do tonight, and also who are in the where are you, where you are from. So we have someone from who's looking in the Ukraine, and we have a psychologist from the Ukraine in the Netherlands, and someone comes from looks in another from another country and is working with refugees from Ukraine, and we have half of our participants are otherwise interested. Well, then let's see what's the responsible alcohol consumption. It's I see that most of you think 1 glass a day and several days non-alcohol at all. That's true according to the World Health Organization. And that are the last insights. Well, everyone is good. 80% is good. Aware that not everyone get a PTSD after experiencing a trauma. 15% is what is found. And yes, the fourth question, you can't contribute to improve the addiction by treating the PTSD. Several research showed that it is good to help the PTSD complaints, but it doesn't result in better effects for addiction. We will come back to that later. It's also good to know that just by making a registration, people change their behavior already. So this question should be asked with true. So we are going to tell you new things today. And you don't want to teach your client to avoid social situations in CBT for addiction. Well, that isn't totally true. So I would choose not true, because in a certain stage, it's good to avoid situations that you are at risk to drink. So this is where we are going to talk about. I think, yes, we stopped with the poll. And now I'm going to tell you about the different substances and about when do we speak of problematic substance use. Yeah. Here we make a classification based on the main effects of the substance. Narcotics, downers, have a calming and relaxing effect. They make you calm, happy, and reduce anxiety. If you have a lot on your mind, you can forget about it for a while. The physical effects include slowed heart rate and breathing, and your muscles relax and your senses start to work less well. Narcotics include alcohol, GHB, and sleeping pills. Stimulants or uppers provide more energy and more alertness. They also provide a stronger sense of self-confidence in many users. Everything in your body speeds up or goes up. Your heart rate goes up, your breathing speeds up, and your blood pressure rises. Your muscles tighten, which can cause jaw cramps, and you get more energy. The only thing that goes slower is your digestion. You are not hungry or less hungry. Cocaine, speed, amphetamine, ecstasy, but also tobacco and coffee are examples of stimulants. Awareness-altering drugs, trippers, and hallucinogens, the most difficult word in this whole presentation. The world looks different for a while. Its use affects mood and perception. You can gain certain insights into yourself and on your environment. And in some cases, this is experienced as a religious or spiritual experience. Physical effects include a slightly accelerated heart rate and blood pressure. Awareness-altering drugs include ecstasy and cannabis. I'm going to say it again. Hallucinogens include LSD, magic mushrooms, ketamine, and other tripping agents. This classification by effect is not a very strict classification. Some drugs have multiple effects. Cannabis can have a narcotic effect, the stoned effect, but provides mild physical stimulation and can be mind-altering in high doses. Alcohol is a narcotic, but at a low dose, it can make you feel fitter. Here are the trippers. If you and your client agree that you will discuss substance use, it is important to be very specific about amounts. This is important for your assessment and during treatment to see the effect of treatment. Alcohol is calculated in units. 1 unit contains 10 grams of pure alcohol. 1 unit of beer is then 0.2 liters, but 1 unit of heavy beer of 10% alcohol is 0.1 liter, just like a unit of wine. So not just ask only for the amount of beer, but also ask for the percentage of the beer. So it's good to realize that 4 bottles of wine contains the same number of units as 1 liter of whiskey. Cannabis, we count in grams. A pre-rolled joint is usually 1/4 of a gram, and cocaine also in grams. Also ask if it is snort or sniffed or smoked, because smoking cocaine is much more addictive than snorting. Prescribed opiates, for example, oxycodone, tramadol, morphine, and benzodiazepines, ask which drug and the dose. Always ask whether this is on a doctor's prescription and whether it is taken according to the prescription. There is the impression that there is an awful lot of drinking in the eastern of Europe. In this overview from the World Health Organization, you can see that the Ukraine falls in the same range as the Netherlands. Only Estonia, Lithuania, and Belarus fall in a higher range. The amount used is important in the assessment, but is not a criterion for determining whether someone has a disorder. But when we look at the criteria for substance use disorder, it's about loss of control of overuse and negative consequences, tolerance, and withdrawal symptoms. Let's talk about talking with your patient about substance use. First, let's see why it is important to discuss substance use with your patient. When someone presents certain complaints, all relevant areas of life that may influence the complaints are questioned. Substance use should also be included in order to get a picture as complete as possible. Substance use has sometimes the function of coping with the complaints, such as safety behavior with benzodiazepines in case of anxiety, and thus reinforces fear. Substances also influence the effect of medication. For example, most antidepressants do not work or work less well if someone also drinks alcohol. And also the use of cannabis can influence this. When someone stops smoking and also uses antipsychotic medication, it is good to pay more attention to an increase in side effects. And it's also good to know that nicotine speeds up the breakdown of antipsychotics. So when someone stops smoking, the dose can suddenly turn out to be too high. In addition, substances can be used as self-medication. Some complaints may therefore show up less because substances are used. Think of a glass to take the worst nerves away from social anxiety, or smoking cannabis to suppress panic attacks. Not everyone is aware that the same use subsequently worsens these complaints. For the best results of treatment, it is important that the client is not using substances. Someone who regularly smokes weed is actually quite constantly under the influence. Even people who drink heavily can still be under the influence the next day. In that case, treating is like painting in the rain. Something sticks, but it doesn't really get pretty. Being under the influence simply has a negative effect on a person's cognitive functioning that's involved with learning, and that's what you need in treatment. So if a treatment doesn't work well, it is good to question the substance use again. Also remember that the client should be informed about the effects of substances on the complaints. This is normal in somatic healthcare. For example, if you have an allergy, the specialist informs you that you must check the ingredients of your shampoo. Likewise with substance use. An example of a colleague of mine is the client who has been treated for depression for years and find out during a consultation that his substance use could have an influence. This was never discussed with him. He stops drinking alcohol and the depression decreases considerably. He files a complaint with the institution because his therapist have been negligent and failed to tell him that his alcohol consumption is affecting his depressive symptoms. This graph shows what can happen to depressive symptoms after 2 weeks of abstinence. 80% no longer met the criteria for depression. Similar results are found with alcohol and anxiety disorder. How to ask about substance use? Well, many people think that patients always lie about their substance use. People would always underreport. That isn't true. Research shows that people don't lie if they are convinced that what they say has no consequences. In Ukraine, you can get a note in your file with several consequences for getting a driving license or some kinds of job. So it was very important for Arkady to convince Maria to be able to talk about her drinking problem. Use is often a shameful subject. People don't like to talk about it, especially when they come for other complaints. By introducing the subject as a standard part, just like you ask about the sleeping pattern or the daytime activities, the threshold is already lowered. Well, inform your patient about how substance use can influence the complaints, and your attitude has to be neutral. No judgment allowed. It's very important to use a screening tool. Screening in itself is a real intervention with effect on use. A screening makes it possible to talk about objective facts with your patient and not to end up in a discussion about opinions where you come up against each other. The more common or natural you introduce a screener, the more normal the patient will experience it. The Audit C is a short screening tool. You see it in the slide, and it distinguishes whether there is a drinking problem, excessive or heavy drinking, and it's available online in English. Research showed that the combination of using a screener and discussing the influence of alcohol on the complaints can lead to drinking 3 or 4 glasses less a week. Let's see what it looks like to discuss alcohol use. This is a very special moment.
Nou, welkom Bart, goed dat je er bent.
Ja, dank je.
Vertel eens, voor welke klachten kom je?
Nou, ik kom eigenlijk omdat ik me de laatste tijd steeds somberder voel. Ik ben al heel veel moe. Ik slaap slecht. Mijn vrouw zegt iedere keer van, jezus, wat ben je sloom geworden eigenlijk. Dat is een beetje wat...
Dus vind je het traag?
Ja, en we hebben het erover gehad en mijn dochter die is zwanger en ik wil eigenlijk ook wel leuke dingen doen straks met mijn kleinkind of zo.
Ja.
Dus dat,
Je wil een fittere opa zijn.
ja,
straks.
en als ik zie wat ik nou doe, ik doe zo weinig. Er komt zo weinig uit mijn handen, dat mijn vrouw zei van ja, als jij straks een kleinkind hebt, wat ga je er dan mee doen? En hoe ga je dat aanpakken? Ja. En toen, weet je, het heeft al vaker opmerkingen gemaakt. Toen dacht ik van, nou oké, ik moet er wat aan doen. Weet je, ik moet in ieder geval onderzoeken wat het nou is.
Dus je baalt ervan en je wilt het graag veranderen.
Ja.
Ja.
En vroeger was ik toch anders. Weet je, toen ik nog werkte en zo,
Ja.
was ik veel actiever.
Oké.
Ja.
En kun je iets vertellen, hoe lang heb je deze klachten al? Vul vooral aan, hè, wanneer ik iets vergeet. Maar als ik het even samenvat, je hebt last van slaapproblemen. Je voelt je niet uitgerust als je opstaat. Je hebt moeite om dingen te doen. Je hebt allerlei plannen, maar het komt er eigenlijk niet van. Ook door die vermoeidheid. En je wilt eigenlijk fitter worden. Je wil straks een fittere versie van jezelf zijn. Niet alleen voor jezelf, maar ook voor je partner en een kleinkind dat er komst is. Ja. Ben ik nog dingen vergeten? Nee. Wat ik nog vergeten ben te vragen, gebruik je ook middelen?
Middelen in welke zin?
Rook je, gebruik je drugs, drink je alcohol?
Nee, roken ben ik 8 jaar geleden mee gestopt. Daar ben ik heel
Wat
trots
goed.
op. Ja, heel trots. Drugs gebruik ik helemaal niet. Dat heb ik ook nooit gedaan. Alcohol drink wel al een glaasje. Dat is het een beetje. Ja.
Oké. En die klachten die je noemt, hè?
Ja.
Daar kan alcohol ook op van invloed zijn. En vind je het goed om een korte vragenlijst in te vullen over je alcoholgebruik?
Ja, prima.
Ja?
Ja.
Heb ik deze. Dan kun je deze vraag lezen en een van deze hokjes aankruisen.
Oké, ja.
Ja.
De eerste vraag, dat is dan hoe vaak drink je alcohol?
Ja.
Ja, oké. Ja, dan is het nummer 4. Dus ik drink eigenlijk elke dag wel wat. Ja. En de tweede vraag is dan van hoeveel drinkt u op een...
Maar hoeveel drink je dan? Als ik nog even mag vragen, die eerste vraag. Elke dag drink ik wel wat, zeg je?
Ja, dus nou ja, ik drink denk ik, ja, wat zou ik drinken? Elke dag 4, 5 glazen of zo, wel. En het weekend wel meer, hè? Dus dat staat er ook zo van hoe vaak drinkt u meer. Dat is in het weekend.
Wat voor drank drink je?
Ik drink altijd witte wijn.
Je drinkt altijd witte wijn.
Ja, dat vind ik
En
lekker.
je zegt 4, 5 glazen. Hè? En hoe groot zijn die glazen?
Gewone glazen, gewoon van de IKEA.
Oké. Want in 1 fles wijn, daar kun je 8 standaard eenheden uithalen. Daar meten we dan mee om het objectief te houden.
Oh.
Als je dat in je achterhoofd houdt, hoeveel drink je dan?
Nee, ik
Hoeveel
drink elke dag nog een fles wijn.
Oké.
Maar bij mij gaat er maar 4 glazen uit.
Oh ja. Dus jouw maat is dan groter dan de standaard eenheid die wij hanteren.
Oh.
Hoe vind je dat?
Hoeveel zei je dat er in de fles zat?
8.
8. Nou, dat vind ik wel heel veel. Ja.
Je schrikt ervan.
Nou ja, ik vraag me dan of dat klopt.
Oké.
Je moet er ook zelf ook een beetje om lachen.
Ja, ik lach meer omdat het je verbaast.
Oh,
maar
ja,
ik hoor het vaker ook van mensen.
Ja.
Maar daarom hebben we dus standaard eenheden.
Oh, oké. Ja, in het weekend drink ik echt wel meer. Ja, dan wordt het wel richting de 2 flessen.
Oké, dus in het weekend 2 flessen en door de week 1 fles per dag.
Ja, mijn vrouw drinkt dan in het weekend ook wel een glaasje mee. Maar ja, die drinkt maar 1 of 2 glazen in zo'n heel weekend. Dus merendeel, dat drink ik dan.
En het is dan een fles van 0,75. Het is
ja,
geen
gewoon
liter.
Een fles. Nee, gewoon een fles wijn. Ja, nee,
okay.
niet. Ik vind 8 al heel erg veel.
Ja.
Dan, als je het
dus
zo
je schrikt
noemt.
ervan.
Ja.
Kun je hem nog afmaken? Dan kunnen we samen naar kijken.
Ja, dus hoeveel drinkt u op een gewone dag? Dan zit u, als jij het volgens mij zegt, dan zit je op tussen 7 en 9, dat is dan 8. En hoe vaak drinkt u meer dan? Dat is dan 2 keer, hè? Dus dat is dan op zaterdag en zondag, maar ook soms ook wel regelmatig ook op vrijdag. Dus 2 of 3 keer in de week die 2 flessen.
Ja.
Ja.
Wat we namelijk weten uit onderzoek, is dat alcoholgebruik invloed heeft op heel veel psychische klachten die mensen hebben. En waarvoor ze zich dus ook hier aanmelden. En daarom wil ik met jou kijken, als je het goed vindt, wat jij ervan herkent.
Oké.
Ja? Kijk, dit is een lijstje met klachten die veel mensen ervaren wanneer ze fors alcohol gebruiken, zoals jij.
Dus jij zegt van, er is een verband tussen die alcoholgebruik dat ik doe en de klachten die ik heb.
Gezien de hoeveelheid die je drinkt, is er een grote kans dat je alcoholgebruik invloed heeft op hoe je je voelt en wat je doet op een dag.
Oh.
En,
dat zei mijn vrouw, die zei dat ook al. Zo van, komt niet gewoon door de drank. Toen dacht ik, nee, ik vind drank heel erg lekker.
Ja, wat we weten is eigenlijk dat wanneer mensen heel veel alcohol drinken, dan kunnen ze deze klachten hebben.
Nou ja, daar herken ik wel een aantal van.
Wanneer we dat alcoholgebruik niet aanpakken, maar de klachten wel proberen te veranderen, heeft dat niet altijd succes.
Oké.
Hoe vind je het als ik dit zo aan je vertel?
Nou ja, daar had ik niet. Daar had ik natuurlijk helemaal niet op gerekend.
Ja.
Niet bij stilgestaan of zo. Ja.
Het verbaast je, maar het geeft me ook een ingang om iets aan je klachten te doen, mogelijk.
Dus jij vindt dat ik eigenlijk daar dan die alcohol ook aan moet pakken?
Het is een eigen keuze die je hebt, maar ik denk dat het wel verstandig is dat we samen kijken naar wat het je mogelijk kan opleveren.
Oké.
Hoe lijkt je dat?
Nou ja, daar was ik niet van uitgegaan toen ik hier kwam. Ja. Oké.
Want wat herken je? Wat op het
Nou ja, ik
lijstje
herken
staat?
natuurlijk wel een aantal dingen. Hè. Die vermoeidheid herken ik. Ik herken somberheid, geen zin om dingen te ondernemen.
Ja.
Terugtrekken uit sociaal contact, slaapproblemen, echt best wel veel. Ja, die prikkelbaarheid, mijn vrouw vindt mij prikkelbaarder. Maar ik vind zelf dat dat wel meevalt. Maar mijn vrouw vindt dat wel. Dat
Dus
ik
je
sneller...
herkent veel van de dingen die daar
Wel, ja,
staan.
best veel, ja.
Vind je het goed dat we er eens 1 uitpikken? Dus dat ik je bijvoorbeeld iets uitleg over alcohol en die slaapproblemen?
Zeker, ja.
Want we weten dat wanneer je alcohol drinkt, heel veel mensen die nemen dat omdat ze zeggen, ik heb moeite met inslapen. En als ik drink, dan slaap ik iets gemakkelijker in. En dat klopt ook.
Ja.
Maar vervolgens, op de langere termijn, verstoort alcohol eigenlijk je slaappatroon. Het maakt dat je sneller wakker wordt tussendoor en dat je niet goed van je remslaap kunt profiteren, waardoor je eigenlijk vermoeid wakker wordt. Is dat herkenbaar voor jou?
Ja, maar weet je, kijk, ik heb wel eens een dag dat ik niet kan drinken, omdat ik een onderzoek heb in het ziekenhuis of wat dan ook. Maar dan slaap ik helemaal niet. Weet je, dan kan ik niet slapen, dan kom ik niet in slaap. Dus die alcohol helpt me echt om in slaap te komen.
Ja, dus dat inslapen, dat herken je.
Ja.
Maar je wist niet dat het ook de kwaliteit van je slaap wel langdurig kan verslechteren.
Nee, dat alcohol, ik zag het altijd als een soort slaapmutsje of zo. Hè? Dus dat
Ja, veel mensen met jou.
Ja. Maar als ik dan niet zou drinken, wat dan?
We zien meestal dat wanneer mensen minimaal 6 weken gestopt zijn met drinken, dat er heel veel klachten opklaren. Maar er zijn ook mensen waarbij dat niet gebeurt. Dus eigenlijk weten we het niet van tevoren. We kunnen niks met zekerheid zeggen. Maar we weten wel dat ongeveer 80% minder psychische klachten ervaart dan voorheen. En als ik dit zo zeg, wat doet dat dan met jouw wens om eventueel je alcoholgebruik aan te pakken?
Well, this was an example, and I'm curious if there are any questions in the Q&A.
Not yet in the Q&A, but I have a question myself, if I'm allowed.
Yeah.
You said that the people tend to be honest about their substance abuse, as long as there are no consequences, right?
Yes.
But if they want to be in treatment, they need to stop with the use completely, or because that could be a consequence, right? That the treatment will be stopped, or that you.
At the beginning of the treatment, you have to set a goal first. We will come to that later. And when people come for an assessment, they don't have to commit yet. They will be informed and then make a decision about what type of treatment they is indicated and what goal they have for themselves. Yeah, and sometimes the type of treatment is also when you have a clinical treatment, then you have to be you have to aim on abstinence. Yeah, but sometimes you don't succeed. But the most important thing is that you keep in contact about it, and you keep on trying to reach your goal of abstinence. Is that an answer?
Yeah.
Oh, not totally. Yeah. Okay.
And there is one other question in the Q&A. What is about 1 glass of wine per day? Is it good for your health?
Yes, that's a question that's always coming back. There are things, and I'm not, I don't know, maybe Sera or Arkady knows that there are some things that are good for your health, but there are also and much more things that 1 glass is not good for. I think the chance to get cancer is higher, and that makes that when you take that both in account, that we come to the conclusion that it's not healthy. And the World Health Organization came to the conclusion. It's not my my decision to
personal.
No,
Yeah.
it's not.
Okay.
Yeah.
It was, if I may add, it was the advice, the Health Council updated its advice, I think 1 year ago, 2 years ago, and before that it was officially that a couple of glasses or a couple of glasses per week are okay, and now they updated the advice and they say it's really healthy. If you go for health, it's 0 basically. Yeah, so
Yeah.
as an official advice, it's 0 now.
Thanks.
I don't see no questions coming via the chat. I wanted to say. So.
Yeah. Okay, then I will ask Sarah to tell us about the next topic. Yes. Thank you. I'm going to talk about the relationship between trauma, post-traumatic stress disorder, and substance use disorders. First of all, why do we bring up this combination of disorders? Well, comorbidity numbers are quite high. In the population of PTSD, about 46% of the patients will also suffer from a substance use disorder. In a population of substance use disorder, around 25 to 34% will meet up to the criteria of PTSD, especially in patients with both alcohol and drug use. So working with one of the two populations, it is very important to be cautious for this combination. So what is the explanation for the association between these disorders? Well, there are several hypotheses. First, there is the hypothesis of shared liability, which says that there is a complex relationship between both disorders and that they influence each other. Second, you have the hypothesis of self-medication, which starts with PTSD and then goes to substance use disorder. And they say that these patients, they use alcohol or drugs to suppress their complaints as self-medication. Third, there's the hypothesis of high risk, and that goes from substance use disorder to PTSD. And this hypothesis says that patients with substance use disorder bring themselves in more dangerous situations. For example, being more at risk for accidents while being under influence of alcohol, or interact in a more unsafe environment with dealers or drug-related crime, etc. And finally, there is the hypothesis of susceptibility, which states that there is a certain vulnerability to develop the both disorders, and they also influence each other. At Jelinek, we are currently running a big randomized control trial called TOPA, Treatment of PTSD and Addiction, where we included patients with both PTSD and substance use disorder. And we found that these disorders already exist for a very long time in this group of patients, 12 years for substance use disorder and 17 years for PTSD. And you see in the last two tabs that most patients did not receive any previous treatment. So the PTSD complaints exist even longer than the substance use disorder. And most of the patients, you see 63%, also say that the PTSD came first. So these results from this big RCT fit to the hypothesis of self-medication, where it starts with PTSD and then the substance use disorder arises. And also in general literature, most evidence is found for the self-medication hypothesis. Therefore, it is super important to be cautious for substance use disorder in the population of traumatized Ukraine refugees. If patients suffer from both disorders, their treatment outcomes will be less favorable. They are using more substances, they relapse more frequently, they have higher comorbidity with other disorders, dropout numbers are higher, and they suffer from more interpersonal problems. So it's a difficult to treat group. Well, although many Ukrainian refugees will have experienced a trauma, this does not mean that they automatically suffer from PTSD. Luz already told you that in the beginning. Although more than half of the people in general will be confronted with a life-threatening situation, only 7 to 8% of the people will develop PTSD in their lives. However, looked at the risk factors of developing PTSD, you see some interesting things. Temperament and existence of other psychological complaints increases the risk, as well as frequency of trauma and knowing the perpetrator, for example, being a family member. And last but not least, lack of social support and bad coping increases the risk of developing PTSD. When looked at the case of Maria, she did not have a support system in the Netherlands. She was isolating herself and she was drinking heavily. All factors that increase the risk of developing PTSD.
So it is good to be alert to PTSD complaints, but trauma does not automatically lead to PTSD. Chances are quite big that your patient does not develop PTSD after suffering trauma. However, that does not mean that trauma does not have an important impact on their lives. It could lead to depression, substance use problems, or even personality disorders. So, although trauma does not necessarily lead to PTSD, you can diagnose this disorder even when your patient is not abstinent. For many other disorders, this is not the case, as Luz already mentioned, because a lot of the other complaints will disappear when a patient stops drinking or using drugs. For PTSD, this is mostly not the case. So, what if your patient has a diagnosis of both substance use disorder and PTSD? What are the implications for further treatment? Well, you could argue to treat substance use disorder and PTSD at the same time. Research indicates that it is safe to do so, and that treating the PTSD on top of the substance use disorder will decrease the PTSD symptoms, and there's most evidence for this parallel treatment. And this is also consistent with the self-medication hypothesis, because if you only treat the addiction, it would not be very helpful, since the cause of the substance use disorder is not dealt with. You would maybe think that according to this self-medication hypothesis, it is even a good idea to only treat the PTSD and not the substance use disorder, and that the substance use disorder will disappear automatically. Well, this is unfortunately not the case. Luz already told you that after the poll, treating only PTSD does not have an effect on the substance use disorder. So you need attention for the substance use disorder as well in your treatment. However, there are also some arguments to treat substance use disorder and PTSD sequential. And with sequential, I mean treating the addiction first and then the PTSD. Well, a recent meta-analysis indicates that treating substance use disorder also has a positive effect on PTSD complaints. Furthermore, many therapists prefer this because they think treating both disorders at the same time is harmful or even dangerous. But for the parallel treatment, there's a little bit more evidence. Okay, so timing of treatment is somewhat questionable. Most evidence for parallel. What about the type of treatment? Prolonged exposure and EMDR are treatments for PTSD according to Dutch guidelines. And for patients with a combination of PTSD and substance use disorder, prolonged exposure is also effective in decreasing PTSD symptoms. However, it is less effective than in patients without substance use disorder, and there is more dropout from the treatment. And as I said before, treating only substance use disorder also decreases the PTSD complaints. EMDR in this group of patients is only studied once, and although the results were promising, more research is needed. In summary, there is high comorbidity between PTSD and substance use disorder. Not all patients who suffer from traumas will develop PTSD. Trauma-focused treatment does have a positive effect on the PTSD complaints, although treating only the substance use disorder also has a positive effect. Most effective timing of PTSD treatment is still unknown, although there is a little bit more evidence for parallel treatment. Prolonged exposure is effective, but dropout is quite high. EMDR is promising, but there is still little evidence for this group. Okay, let's see if there are any questions.
Yeah, there was a question from Maxime. He only sent it to the panelists, but I think everybody should see it now. So maybe Arkady, you can help.
Yeah, I can help translating. This question is about the coffee. What about the coffee? If you don't have no comorbid somatic problems, how much coffee is healthy to have? How much coffee is healthy to drink? And what about milk in the coffee?
Okay, so this is a question about the first part more.
Yeah.
How much? Do you know that, Luz?
No.
I think but that's just my own reference that 2 cups of coffee is okay, but that's something I just know for myself, and it's not in some kind of guideline.
No, I'm not aware that there are that there's a guideline that we use in our patient. No, so I'm sorry, I can't answer it the way we can tell it about alcohol.
Well, we do address drinking coffee and also drinking, like, how do you call it, like Red Bull and types of drinks like that. And if somebody, of course, drinks like 8 cups of coffee a day, then you need to also include it in your treatment. But it's not a goal per se, like they have to quit drinking coffee or something like that. Yeah.
We have coffee machines in this building.
Yeah. And maybe if somebody has sleeping problems, then of course it can be quite smart to stop drinking coffee for a couple of weeks and see what happens. That's never a bad idea, of course. Yeah.
I would say also keep in mind that coffee you drink orally, so it takes about half an hour, 45 till 45 minutes until you actually feel the effect of the coffee. This is sort of slowest way to consume something psychoactive. So if you would have 3 coffees after each other, then very probably you'll feel the effect of all the 3 together. And maybe if you indeed have a problem falling asleep, yeah, you shouldn't have coffee later in the afternoon, late afternoon.
Thank you. And Sarah, one more question about diagnosing PTSD when people are have an addiction as well. How do you properly diagnose it when people are like lower in their complaints and maybe they don't have any like flashbacks or other PTSD effects?
You mean how do you diagnose PTSD?
Yeah, if there is a severe addiction as well.
Yeah, we use the CAPS, the clinical administered PTSD symptom, I think. I always say CAPS, I don't even know by head where it stands for. And you can also do it with the SCID-S, where you can diagnose all kind of complaints. And you can just do it the same as when people are sober. The only thing is when people are heavily under influence, of course, it's very difficult to have a conversation. Then you cannot surely set a diagnosis. But when people are using alcohol or drugs, you can administer the CAPS. Yeah. And this is the golden standard for diagnosing PTSD.
Invallen? Yeah. Maybe you also mentioned that people under influence have less complaints when they're still using alcohol, for example. Well, then when you're going to treat the substance use disorder, you can do it again or ask again, how is it going right now? And you can consider to do the CAPS after abstinence has reached.
Yeah. Thank you.
Any other questions? Not in the chat, I see. No. Okay. Okay.
Okay, then I will pick it up right here to talk about what you can do in treatment yourself and when it is wise to refer your patient. In this webinar, we want to convince you that you can do a lot yourself for your patients with substance use problems. Just by discussing it, paying serious attention to it, and doing a screening with feedback, you make a difference. If you then take the time to provide psychoeducation about the effects and consequences of use, you are also doing a good job. Don't think you need to know everything. The opposite is the case. Be curious together with your patient and look for information that's relevant to your patient. The Jelinek website contains a lot of information which you can use in combination with Google Translate. Then ask your patient what conclusion he draws from this information. Then it's good to mobilize support, help from the environment. And in addition, there are also meetings of the Alcoholics Anonymous. On the internet, we found 2 weekly meetings in Kiev and also an English meeting online. In the Netherlands, Arkady has put it in the chat. In the Netherlands, there are online self-help module. We didn't find this in the Ukraine, but if you have any tips for meetings or self-help, please put them in the chat or let us know. If your treatment is not successful, it's good to consider referring your patient, and in doubt, you can always call the number of the Jelinek Adviesline and discuss it. Let's see when to refer your patient to addiction care. Some people only think that a detox is the only treatment for addiction. In addition, they think that if they are locked up without substances, their addiction should be solved. Maria was also convinced that it worked that way. Arkady had to take time to explain there were more options for her for treatment. A detox is not a treatment at all. In such a short time, someone doesn't get tools to change their behavior, and behavior that's conditioned by regular repetition. A detox aims to detoxify as safely as possible. Someone who consumes large amounts of alcohol every day shouldn't stop using it at once, because that's dangerous. If people can and are allowed to do without a detox, a reduction of 10% each day will be the maximum to fade out the alcohol consumption. During a detox, this can be supported by medication and it can be better monitored. Also, for example, GHB. If patients have to take it every few hours, they shouldn't stop taking it at once. Also, then a detox is important. So what's the treatment? Cognitive behavioral therapy is a treatment that's well researched, and also the 12-step model underlying Alcoholics Anonymous provides treatments that are well researched. We will go further into the CBT in a moment. Addiction care can also be supported by the pharmacotherapy that's provided. That's another reason to refer your patient. And in the Netherlands, many addiction care institutions can provide more intensive treatment if necessary. Cognitive behavioral therapy is an effective treatment that's well described. Here you can see that various manuals have been published in Dutch and online there are also manuals in English available. We couldn't find any in Ukraine or Russian. So if you have found something, please inform us in the chat so your colleagues and we can use it. A very bad misunderstanding is that the treatment of addiction is not effective. That's not true at all. The treatment results are comparable to treatments for depression and anxiety disorder. 50% recover well, and in about 3/4, you see an improvement. And relapse rates are comparable as well. If you apply CBT, it's important to use motivational interviewing techniques. So let's look at that first. The introduction to motivational interviewing is given by William Miller, one of the authors of the book that Arkady found out to be translated in Russian.
Fundamentally, motivational interviewing involves a change in role, a change in how you think about what you're doing. You're not the expert there to fix the person. You don't have to make the person change. The truth is, in fact, that you can't make a person change. You don't have to be the one to come up with all the good ideas. A person with really good ideas is sitting across from you and may have better ideas than you do. It's not like a competitive sport. It's not like wrestling where you try to defeat and pin and outsmart and outwit the person. It's more like dancing together, moving together, adjusting your movements to the other person. Overall, motivational interviewing is not a directive approach. Neither is it just a following approach. Following is listening to the person and kind of going wherever they go. Motivational interviewing is in the middle, between those two, and we describe it as guiding. If you go to another country and you hire a guide, you don't expect the guide just to follow you around. That's not what you're looking for. Neither do you expect the guide to order you when you will arrive, when you will leave, what you want to see, what you will enjoy, what you're going to do. That's not a good guide either. Good guiding involves good listening, as well as using your own expertise. A good guide will find out where you want to go, what you're interested in, what you're hoping for on this journey, and then help you get there using his or her own expertise, enjoyably, safely, efficiently, perhaps. That's the guide's job. Not solely directing, not solely following. There's some of each in it, but it's a blend of those things. This may or may not be the way you've been thinking about your own work, but we invite you to try it out. Fundamentally.
So motivational interviewing is a conversation about change, where you strengthen the motivation of your patient for this change. Motivation is not a fixed fact. It's also not a personal characteristic. Motivation is subject to change, and our job is to mobilize, enlarge, and strengthen it. When you talk about change, you will hear ambivalence. Two kinds of languages are mixed up: change talk and sustain talk. For example, I want to lose weight, but I've already tried everything and I can't keep up. Or I want to exercise more, but I can't make time in the evening. It works much better if the patient himself speaks out loud the arguments for change. People become more convinced of what they hear themselves say. Ideal is therefore if the patient himself speaks out loud the reasons for change. Motivational interviewing was developed in the treatment of alcohol addiction. This ambivalence is so strong in substance use. On the one hand, there's the enjoyment of the use, but on the other hand, the suffering from the consequences. Research clearly shows that the more change language the person speaks in a session, the greater the chance that he will actually change his behavior. In motivational interviewing, 4 processes are distinguished. The first is a precondition for the second, and so on. The first is engaging. That is the process by which 2 parties enter into a useful contact, a working relationship. Sometimes it can be done in a few seconds. Sometimes that can take weeks. It ensures that the patient trusts the therapist and wants to enter into that relationship. The second is focusing. That is to get agreement to what you're going to work on together. What does the client come for? And what's the therapist's agenda? A goal, a dot on the horizon. For example, the client is short of breath and has inflammation of the airways and wants to get rid of the complaints. The doctor wants to discuss smoking. They have to get agreement on what are we talking about. The third is evoking or eliciting, and that's the core of the motivational interviewing. Let the person tell as much as possible arguments for change. We'll get back to that later. The fourth, the last, is the planning. That's the link between change language and change behavior. The first step in our manual, our CBT manual, is to identify the client's reasons for addressing his substance use. We used to discuss both the disadvantage and the advantages of changing or stopping and of continuing the use as well. However, it's very clear from the research into motivational interviewing that talking about change also leads to change in behavior, and that sustained talk doesn't lead to change. That is why at this step in the manual, we only discuss the disadvantages of continuing to use and the benefits of stopping or reducing. Only when you are in the first process, the engaging, it's sometimes good to consider the disadvantages of stopping to show understanding for what the use had brought the patient. But as soon as you are engaged in the eliciting process, that's no longer advised. How do you ensure that your patient speaks change language? Well, it's important to use open questions instead of questions to which you can answer yes or no. Why do you want to change? Instead of, do you want to change? A nice way is also the use of the ruler. On a scale from 0 to 10, how important do you think it's for you to stop drinking alcohol? Perhaps the client will say an 8. If you ask the client why not a 7, he will mention all the arguments that make it important for him to stop. You can also do this with the question on a scale from 0 to 10, how much confidence do you have that you will be able to stop? Even with a 1 as the answer, you can ask, why not a 0? Inviting the client, your patient, to speak out about his little bit of self-confidence. If you ask, what would be the worst thing that could happen if you continue to use alcohol? Or what would you like the most to change if you stop drinking? Then have your patient imagine the outcome and then tell you as much in detail as possible what it looks like. The question to ask is when you want to go to the last process, the planning to change, is the key question. If you hear yourself saying all this, what is your conclusion about your desire to change your drinking? You heard Lynette this question saying a few times. Change talk. These starting of sentences are starting of sentences with change talk. You can recognize them, and sometimes all you have to do is say, tell me more about it, and then you're a good motivational interviewer. If the patient concludes after the key question that he wants to change, it's time to set a goal so that you can then make a change plan. The goal must be formulated smart, so concrete, feasible, and measurable, with a date, a duration, the exact amounts for your patient uses. For example, from Wednesday, the 6th of July, I will only drink 2 units of alcohol on Friday or Saturday. The goal can therefore also be about controlled use. So that's what you are talking about, Esther. You can have a goal on drinking less, but it should be fixed in amount. That is why it's so important to determine the amount in very concrete terms. Otherwise, you can never determine whether the goal has been achieved or not. Just drinking a little less, and preferable not during the weekdays, is not a good formulated goal. Goal setting is also accompanied by motivational interviewing. It's important that it's a goal of the patient, but you do want your patient to be informed about what a good and a sensible goal can be within treatment. Motivational interviewing has a very clear idea about giving information. First, ask for permission to give information, and then ask what the patient knows about the subject. And then you can add your information. And you can finish again with a key question. If you hear this information, what does it mean for your goal you want to set regarding your alcohol use? Especially when it comes to major risk, if someone continues to drink, such as pregnancy or when driving under the influence, and in case of aggression. Then you really want to actively aim for the abstinence goal. Then it's very tempting to simply tell the patient what his goal should be. But the more it is the client's own goal, the greater the chance that it will succeed. So remember that you can also set a goal for a very short period of time and then evaluate together. This is much easier for the patient to oversee and therefore also more feasible. If you say, let's start with 1 week, well, then you know that you will have to get back to motivate the patient after 1 week to continue the abstinence for a next limited period of time. If your patient wants to learn drink in a controlled way, it is important to first target a period of abstinence. The abstinence goal is much easier to achieve because as soon as someone uses some substances, his control over his behavior diminishes, and then it's hard to stop after just 1 or 2 drinks. Now we have already discussed 2 parts of the cognitive behavioral therapy manual: motivating for behavioral change and the change plan. The CBT manual consists of many different parts, and I would like to focus on 2 parts, namely the registration of use and the self-control measures. But in order to understand this properly, I want to reflect on 3 phases in which you go from just having fun using substances into an addiction from which it's difficult to escape. The first phase is the phase in which someone goes for the reward, having fun, excitement, or being tough. Or the reward that you feel less of the sadness, of the fear, or of the worries you have. If you like it, you will do it more often. The second phase, there are some negative consequences of the use of alcohol, for example. Sometimes they are just limited to an awful craving at the moments or in situations that you are used to use before. And what can you do the best? Well, indeed, use some alcohol. Then the craving or the other misery will be over at once and you will feel great again. And after a while, you have used so many times that you developed a strong habit or behavior pattern, like a path you can't deviate from. Register is the first step to gain insight in your own usage pattern. It's good to know that just make a registration of your substance use is an intervention in itself that already results in a significant change in the amount of use. Trying to register your drinks can be such a confrontation that it helps to decide not to drink that beer. To get a good idea of your use, it is important that you make a registration of one particular moment and analyze it. When, at what time, where were you exactly, who were with you, what were you doing? Maria started right away yesterday when she woke up at 10 a.m. and had a huge hangover with the leftover beer. she found. She was in her room and alone, and she was in bed and did nothing. She had intrusions about the trauma and thoughts about not being able to make anything of her life. And physically, she felt broken. Emotionally, she felt anxious and sad. The behavior was drinking beer, with the result that she experienced less hangover and could go over her worries for a while. The registration gives an impression of the difficult situations in which you are used to drink your beer or wine. That gives you starting points to think about what you could do to prevent yourself from drinking in that situation. We call that self-control measures. Now we are going to look at a conversation about self-control measures with the same patient, Bart.
Oké, Bart, welkom weer.
Mhm.
We zijn inmiddels in sessie 3 van jouw behandeling. De vorige keer hebben we samen jouw doel vastgesteld. Je hebt besloten om 6 weken lang helemaal niet te drinken. Je bent inmiddels bij de arts geweest. Die heeft je geadviseerd wat je kan doen ter ondersteuning. En jullie hebben een plan gemaakt hoe je dat gaat aanpakken. Een stopdatum vastgesteld.
Ja, dat is fijn.
Ja, en vandaag gaan we het hebben over zelfcontrolemaatregelen. En dat zijn eigenlijk vaardigheden die je inzet om je doel te kunnen behalen. Bijvoorbeeld op de momenten dat je eerder gewend was om te drinken. Vind je het goed als ik je wat uitleg welke varianten er zijn?
Zeker.
We hebben eigenlijk 3 verschillende soorten. Die laatste horen een beetje bij elkaar. De eerste gaat over vermijding. Vermijding van bepaalde triggers om te gaan drinken. Dan kan je denken aan het vermijden van bepaalde plekken of situaties. Of misschien bepaalde mensen die je voorlopig moet vermijden. Bij de tweede gaat het over ander gedrag. Op de momenten dat je eerder gewend was om te drinken. Bijvoorbeeld iets doen ter afleiding. Iets ontspannends doen. Of iets anders drinken op de momenten dat je dronk. Dat je alcohol nam. En die laatste horen een beetje bij elkaar. En die gaan over jezelf belonen. Of een negatieve gedragsconsequentie op het moment dat je je doel wel of niet haalt. We weten dat het heel effectief is als je van tevoren voor jezelf een beloning bedenkt. Als je je doel haalt, dan ga je bijvoorbeeld een bos bloemen voor jezelf kopen of iets lekkers te eten. Het mag iets heel kleins zijn. En als je je doel niet haalt, om ook iets af te spreken wat je gaat doen als een soort gedragsconsequentie. Het liefst iets wat je uitstelt of waar je een beetje tegenop ziet, maar wel iets waar je uiteindelijk een positief gevoel aan overhoudt.
En wanneer doe je dat dan?
Dat doe je als je je doel niet haalt.
Oh,
Dus als
straf.
je toch een keer gedronken hebt, je zou kunnen zeggen een straf. Wij zeggen liever een gedragsconsequentie. Je kan bijvoorbeeld denken aan een klusje in huis, een keer een schuur opruimen, iets wat je uitstelt en waar je uiteindelijk toch een goed gevoel van krijgt als je het hebt gedaan.
Oké. Ja.
Als we het zo langslopen, is er iets waarvan je nu al zegt, dat herken ik, dat zou mij kunnen helpen?
Nou ja, wat ik zeker weet, als het gaat over die vermijding, dat is dat 4 uur moment door de week, ja, dan moet ik iets op verzinnen. Want dan gaat bij mij de alcoholwekker af, zo zou je kunnen zeggen. Ja.
Dus dan zit je misschien meer een beetje hier, van wat kan je gaan doen om 4 uur of misschien iets eerder, in plaats van thuis te gaan zitten en alcohol te gaan drinken.
Ja.
Wat zou nou voor jou een goede activiteit zijn waar je afleiding uit haalt? Iets wat je ook prettig vindt om te doen op die momenten?
Ja, kijk, ik was natuurlijk vroeger altijd, heel veel buiten en in de natuur en zo.
Ja.
Dat is er echt de laatste jaren weer ingeschoten.
Ja.
Het zou heel goed zijn als ik bij wijze van spreken om 2:30 of om 3 uur de deur uit ga. En dan naar buiten, de natuur in en dan pas thuis kom, zo rond 5 uur als Maaike weer thuis komt van haar werk. En dan overbrug ik dat moeilijke moment. En dan kan zij me bij wijze van spreken later op de avond ook nog een klein beetje steunen.
Ja. Ik denk dat het een heel goed idee is, want je slaat ook meerdere vliegen in één klap. Hè. Je bent en de deur uit, dus je bent en weg van huis. En je doet iets waardoor je een beetje in beweging bent en iets wat je eigenlijk al wat langer wilde doen. Ja.
Als het gaat over vermijding, dan denk ik meteen aan geen drankje in huis. Dat heb ik ook al met Maaike besproken. Zo van, want als het in huis is, dan gaat het ook op.
Dan ga ik hier opschrijven, de deur uit om 1 uur of 3, zei je. En hoe zullen we dat noemen? Wandelen buiten of fietsen? Wat doe je graag?
Nou, vooral wandelen en af en toe ook wel fietsen, maar het is vooral wandelen. Ja.
Wandelen, oké.
Ja.
Je mag meeschrijven trouwens op bladzijde
ja.
19 van je werkboek.
Oké.
Dus hier schrijven we op om 3 uur wandelen.
Oké.
En je zei bij die eerste, hè, vermijding is belangrijk om geen drank in huis te hebben.
Ja.
Dan gaan we even naar die laatste 2. Is er iets wat je zou kunnen doen om jezelf te belonen? Laten we zeggen, hè, je hebt afgesproken, je gaat 6 weken niet drinken. Om bijvoorbeeld 1 keer per week een moment te kiezen om te zeggen, hé, als ik het gehaald heb en een week niet heb gedronken, dan beloon ik mezelf. Het mag iets heel kleins zijn. Een bos bloemen voor jezelf kopen, naar de bioscoop met Maaike, iets voor jezelf te eten halen, wat jij heel lekker vindt. Wat je anders...
Nou ja, wat ik wel lekker vind, ik zat te bedenken, denk je, zo van, goh, voorheen, vroeger had ik regelmatig visje, maar Mike houdt zo niet zo van vis. En dus om dan, als het me lukt om een week niet te drinken, om dan gewoon voor mezelf een lekkere vis te halen. Zo.
Ja, oké, goed
Ja.
idee. En
Ja.
kan je een moment vinden in de week wanneer dat geschikt
Nou ja, bij
is?
ons is op vrijdag altijd de markt en zo.
Oké, ja.
En om dan vrijdag naar de markt te gaan en dan een vis te halen.
Heel goed idee.
Ja.
Ja. Dan heb je ook meteen weer een uitstapje, hè?
Ja,
Je bent dan
dat is
ook
al-
weg.
Ja, alleen is de markt op 's ochtends.
Oké,
dan, hè.
oké.
Ja.
Dus als je vrijdag een week niet gedronken hebt, je doel hebt gehaald, dan ga jij een visje eten.
Ja.
Oké.
Oh, dat staat hier. Ja.
Hey, en als je het nou niet hebt gehaald, kan je iets bedenken van wat ik net noemde, hè? Een soort rotklusje in huis.
Oh, dat zijn godklusjes zat, want ik heb heel veel niet gedaan
Oké.
de laatste jaren. En nou ja, wat in ieder geval, we hebben zo'n heel mooi pad in de tuin.
Mhm.
Er liggen hele mooie steentjes. En, maar dat is volledig overwoekerd. Hè? Dus je kan bijna een pad niet meer zien.
Dus dat moet vrijgemaakt worden.
een rotklus is dat pad van onkruid omdoen. Ja.
En even kritisch, hè? Stel dat het je gaat lukken om 6 weken niet te drinken. Kan dat blijven liggen, 6 weken?
Ja, dat ligt al heel lang zo. Dus
Oké.
dat
Dus
maakt...
niemand wordt boos als je dat nog 6 weken laat.
Nee. Worden we blij als het wel lukt om
Allebei,
daar wat...
Oké.
Alleen het is wel meer dan een uur werk of zo. Hè. Dus dan moet je het eigenlijk in soort
Misschien
stukjes opdelen of zo. Ja.
Oké.
Maar
Maar dat
mooi
pad
begin.
vrijmaken is wel iets waarvan je zegt dat is iets wat ik kan uitstellen en waar ik een beetje tegenop zie. En als het me niet gelukt is om dan een week niet te drinken, dan ga ik dat doen in het weekend.
Ja.
Oké.
Ja.
Dus dan ga je niet dat visje halen, maar dan wordt het pad
Ja.
vrijmaken.
Ja.
Okay. Well, Esther has actually already explained it. There are 3 types of self-control measures. For Maria, avoiding of being alone is important because then her intrusions are less and those are triggers for her. So in the treatment, it is important to look for a kind of daily activity so she isn't that much alone. Maria is a musician, and an important thing to do is to practice again and look for options to play with other musicians. But she should also not go near the liquor store and not go to the supermarket alone, and certainly avoid the corridors with drinks because they make her craving. She also has to avoid the other refugees who drink, and that is quite a challenge that she has to think about, because on Friday evenings it is a tradition that people drink together. Other behavior is about not going out drinking together, but for example, taking an evening walk and getting an ice cream at the corner. The third form is about consequences, rewards and annoying chores. Many patients find it childish to reward himself. So Maria will also have to be convinced that rewarding the new behavior really works. For example, after 3 days without alcohol, choose something from the giveaway market. Chores that you can think of are helping with cleaning the shelter, or helping with cooking, or cleaning your own room, looking after the children or fellow residents. It's important that the chore is satisfying and thus keep you from feeling guilty about your use. Let's see what you can do in therapy with possible PTSD symptoms. Of course, it's good to focus on that too, but realize what Sarah told. First, see if there's really a PTSD. How does it react on the substance use disorder treatment? And be careful that adding the PTSD treatment doesn't make her drop out from the treatment of the substance use disorder. But with a full-blown PTSD, it's worth to treat it right with a trauma-focused treatment, not because we think it will help her for an alcohol problem, but for a PTSD, it is a good idea. Well then, we came to the end of our presentation. Are there other questions?
Yes, thank you very much. Very interesting to see the videos as well. I thought there were some more questions. There was one about, yeah, this is a psychologist who says that she is advising patients to not drink before or after the therapy session.
Yeah.
Is it something you would suggest as well?
Yes, that's what we always start with the intention to be abstinent at all. But if you don't succeed, then indeed 24 hours before and 24 hours after the therapy session, we ask our patient to be sober. Yeah. PTSD session, yes, yeah. That's important. Yeah, the trauma-focused PTSD session. Yeah.
And the other sessions not? Isn't
well, of course, but for the PTSD sessions, you must realize that it's really working hard, and there's happening a lot in the head to have good results of that session, and it would be a pity if someone does that hard work without result, and just coming to talk about substances is, well, I think it's not that intense as the PTSD treatment sessions are.
okay.
And Luz, I was wondering, when you showed this this case of Maria, and that she has to avoid being alone, but on the other hand she has to avoid being with drinking company as well.
Yes.
And I can imagine that it happens more often, especially with displaced people, that they are trying to be together and have some relaxation or alcohol use. What would you suggest in those cases?
Yes, I think it's quite complicated. Yeah, something you ask is to look for people to be with without using substances, and well, you have to look for and help them also to look for places where the use of substances is not normal, and then indeed things like meetings of the Alcoholic Anonymous are options then.
And I also think opening up to the environment is very important for that. because maybe if Maria asks the other people there to not drink in her company or do something else, drink a cup of tea, then they might say, yes, of course, we can help you. And then you have the social support and you don't have to avoid social contact.
Yeah.
So, opening up to your environment is also quite important for that. Yeah.
There's another question. What if drinking of alcohol is coping for the stress and the war and memories of war? And so I can imagine that you think, okay, I drink something because it's too much for me at the moment. And well, you said something about when it's really a problem. So
Yes.
that's also, I think, a balance.
Well, no, I don't think. I think the use of alcohol is a kind of coping that is not helping, and the balance is very quick in the bad way, because the how to say it's because certainly when it becomes a normal part of your daily life, and when it the amounts are more than it feels okay, and it gives lots of bad feelings the day after, then next day is also a more difficult day. So I think the balance is very quick going to not a good idea.
Yeah.
Yeah.
Okay.
And Arkady will.
I think in my experience, what you also create on the longer run is that, look, indeed you get a relief of the symptom on the short term. But in the meantime, you're working, basically actively working on creating a new problem, an extra problem. And so the question is actually, do you need this extra problem 2 months later, let's say, or half a year later? You know, the symptoms are not going away before you treat it. So you will get the symptoms, but you will also get another problem, which is the alcohol problem on the longer run. I understand that it's maybe not easy to ask yourself, but ask yourself, do I need 2 problems or I'm better off with 1? And the second thing I thought of just now is, look, alcohol often make people less active. So it means that you will very probably have less effort to look for help to solve the original problem, to solve the PTSD. So basically, I already give you like two reasons not to, because, and you will look for help less effectively because you're less active, and you're creating a second one. That's my
Yeah. Okay, thank you.
And maybe one last question to Arkady as well. Are there important differences in the way Ukrainian and Dutch people look at addiction and treatment?
I would really explore the details. There is quite a lot of stigma that's surrounding addictions. In my experience in Ukraine, so people are not very often open about it, not immediately open about that. There, you really have to explain that there are no consequences. It's things you discuss here and stays here, and it's stigma is a problem, of course. Very different experiences than in the Netherlands can be a problem as well. I mean, there are all kind of practices that we don't use here. For example, some medication that you get as depot and stuff, which are We don't, and very often people do not have experience with the talking therapy, with the psychotherapy. So you have to explain that there is a therapy that, and it's effective. It works. It's not like you. It is effective. People often do not believe because if they don't look for help very often, of very on the earlier stages. So at the point that they come for help, the problems are already quite escalated, and they have already usually a couple of unfortunate experiences with the therapy. The therapy that didn't work, so they might not look for help because they think, okay, I'm lost cause anyway. It doesn't work for me, which is not that, which is often not the truth. So that's my.
Okay, there's one other question on the Q&A, and that's one for Sarah, I think. Can be the reason one another. PTSD is a reason of addiction, or addiction can be the reason of PTSD. You said something about this already, but I think maybe you can explain it a little bit more.
It can go both ways. There are several hypotheses, and one is that it starts with PTSD and then goes from SAD. It's the self-medication hypothesis, and there's also a hypothesis that stated it starts with SAD and you are in more risky situations and therefore also have more chance of developing trauma and also PTSD. And there are the hypotheses where it influences each other and there is more of a general reason that both disorders occur. So there are different hypotheses, but the self-medication has most evidence, and that starts with PTSD and then the SAD occurs, the substance use disorder.
Okay.
Yeah.
Okay, clear. Thank you.
Okay.
Okay, I think no more questions. So I think we're gonna end this webinar. And Luz and Sarah and Arkady, thank you so much for this very, very interesting webinar. I learned a lot, especially about the unjudgeable way of asking questions to the clients. And also I didn't know the interference between smoking and antipsychotic medicine. So, and a lot more. So thank you again.
Thanks again, Luz and Arkady. Bye-bye.
Bye-bye.
Bye.
Thank you. Bye-bye.